Yes, now we're now live.
Right, good evening everybody and welcome to the Adult Health and Social Care Scrutiny Board on the 15th of July 2021. I'm sorry that the weather is so nice outside and we're all stuck inside on the Zoom meeting, so we'll get through the business, I'm sure, as swiftly as possible. Just before I do start, I would like to pay tribute to Councillor Naeem. It's a real sad loss to the council. It's always sad, no matter which party, whatever, we all serve for the good of the people out there, and he certainly did. He served on this scrutiny panel and he was very, very thorough, asked the questions and attended when he wasn't well towards the end, but he still attended these meetings. So a very, very special tribute to Councillor Naeem from us as a panel. I equally understand there is some additional sad news with the loss of Councillor Sweeney as well. So I've worked alongside Councillor Sweeney. We did in fact, actually, we carried out the review of the doctor's surgeries in the Upper Valley, and I've worked alongside Councillor Sweeney equally. Pay my tribute to Councillor Sweeney and give our best wishes to Ali as well from the panel itself. So that's unfortunately a sad start to the meeting, and I'm sure further tributes will be made at the full council next week for both these people. So we're on Calderdale's council's YouTube site. So welcome to anybody who's listening in. And so let's get on with the agenda. So substitutes nominated for this meeting. I do understand we have Councillor Clark on behalf of Councillor Durrans. So welcome, Councillor Clark. Thank you for stepping in once again. It's always good to see you on board. Right, any other substitutes? Everyone else is here. So members' interest, item number 2, for members to declare their interest at the relevant time. Admissions to the public, it's not recommended that the public be excluded. It is being streamed via YouTube, so they're welcome to see all the events that are taking place this evening. So we now go on to item number 4, which is minutes of the Adult Health and Social Care Scrutiny Board held on the 17th of June 2021. Other than the fact that actually one of the substitutes was actually Councillor Holdsworth, I think I'd like to state those as a true record. Anybody someone like to propose and second those? Councillor Barnes, thank you, and a seconder as well. I'm more than happy. Yeah, thank you, Councillor Hutchinson. So we agreed that there's a true record of the actual minutes themselves. So we've come on to item number 5. Welcome everybody that's come on board. Welcome to Rona, Debbie Robson. So looking on my screen as well, Margid and sorry, Naeem as well. So welcome on board. So item number 5 is a Burnt Bridges report. This is previously come as a draft report to the scrutiny panel. It's not easy reading, and it's quite extremely saddening in various ways, of course. But actually, it's about moving forward and actually learning lessons from what's previously what's been. So we have had the report. So who would like to lead on this? Rona, welcome.
I understand Sean Cook is.
Yeah.
He's there.
He is. Sean, welcome. Would you like to add anything to the report before we open it up to members? Just before we do, just the method of putting your hand up in this one is on the bottom of the screen. There is a button called Participants. If you click on the participants, there is a raise hand facility. So if you want to raise your hand that way, and we'll capture you in the relevant order. Just a bit of housekeeping there. So Sean, over to you.
Thank you, Chair. I won't go into the detail of the report. I mean, it is laid out hopefully fairly clearly throughout the report, but in essence, the Scrutiny Committee asked for an update as far as the progress taken by the various agencies following the Burnt Bridges review commissioned by the Safeguarding Board that was published earlier this year regarding the 5 men who were living street homeless lives and who tragically died. This is in essence, therefore, just a progress report as far as where we are and how various agencies now are beginning to work much more closely together, particularly around healthcare and accommodation. And as the report outlines, we've now have quite a number of projects. They're not complete by any means. They're ongoing pieces of work because it is such a challenging group to work with, particularly around the level of disengagement and how services literally have to wrap themselves around these people, not literally quite, but kind of be very agile as a set of organisations to work with people with very complex alcohol, substance misuse problems, accommodation issues and so on, whereby they can disengage and re-engage. And it's really important, the bottom line with a lot of this work and the models that we're trying to develop is to make sure that we've got accommodation projects as well as health projects within accommodation projects, and particularly as far as our work at the moment, as far as an integrated single point of access for this group of people. They're small in number, but they are growing in terms of their complexity and their lives. And there are other groups around them that if we're not careful and we work with those, particularly women suffering from trauma, domestic violence and so on, they can easily fall into that group. So in essence, I've laid out a number of kind of projects that public health colleagues, the voluntary sector in particular, and health have been working on. And we've got health colleagues here today to also add to that. And then the final part of the project really report is about, and there have been dedicated resources over the last kind of year to make sure that we are targeting our work towards this group as a group of agencies. And the key piece of work that we want to complete, which is at the end of the report, is, as I've stated really, a multidisciplinary, very responsive, agile, single integrated approach to work with this group. So I, with colleagues from public health in particular, but also SWIFT, the CCG, and other agencies, the voluntary sector, particularly housing colleagues, drug and alcohol, substance misuse services, are working very closely as part of the Making Every Adult Matter model, and looking at research and practice models elsewhere, particularly one that we've identified that could fit Calderdale quite well, from Doncaster, that we're looking to shape up to see how that would fit around the needs of this group in Calderdale. So in essence, that's the report as far as the projects are concerned and the progress to date.
Thank you, Sean. Would anyone from the CCG like to comment any further on the report itself before we go to questions? Councillor Megan Swift, in that case. You're probably on mute, so you just... You're still on mute.
You're still on mute, Megan.
Am I still?
No, we can hear you now, Megan, yeah. If you continue, okay.
Yeah, I don't know why I can't get the bottom of the picture. Yeah, everybody seems really relieved and happy about this, or any officers I talk to, and it's obviously moved on. But it doesn't seem, people out there don't seem to be able to tell me that it's moved on and made them any safer. You know, all that seems to be happening now is that the police go around, and if there's so much as stand up and look the wrong way. They put them in the cells until the next day. And I don't think it's good. I don't think it's as good as I would have expected it to be. I mean, we waited 2.5 years for the flipping report. Then we asked for coming back. Now, there's lots of bits in here I don't really understand, but I believe now that there's something to do with homeless people at, is it 42 Market Street? But I heard that from somewhere else. I didn't hear it from via the council, which, you know, is what we went off on really at the meeting. We've got to find a way of making sure that people know what people are doing, and we can help more if we know, you know. Anyway, that's all I had to say, really.
No, thank you, Councillor Swift. Sean, do you want to come back on that at all?
I don't mind coming in if that helps.
Yeah, of course, yeah, of course it does, yeah.
Yeah, so I mean, I would just push back on the idea that not much has been done. I mean, obviously, I've picked up this brief kind of halfway through, but I mean, you know, the report is a robust one, and actually speaking to people around the report who put it together, so it's quite unusual for a council to put so much resource into working out what we don't get right and how we can improve it. And I think that's something that actually I'm quite proud of us having brought this together and actually looked at that and then acted on it. And in terms of actual things, obviously the tangible results aren't always, is always much more visible when you get these things wrong than when you get them right. But the thing that they are doing in terms of the tangible results, obviously there's the supportive housing project, which is the 8 units of people who've got multiple complex needs to kind of help them out of that situation, but also making sure that we're actually capturing people. You know, the big thing that comes through in the report, I'm sure you'll all agree, is that everyone in that report had reached out and hadn't been picked up, and it's making sure that we have that whole thing activated, so you get a multi-agency approach that people are dealt with where they come. And I think those are the learning points, and some of that is kind of you know, some of that won't be as tangible. So, you know, you will see the very visible stuff of when police have got involved or something like that, but you probably don't see kind of day to day the tangible impact of us taking kind of the small steps that aren't as as sexy almost. So I think sometimes it's easy to miss that. And I would push back on the idea that not anything's been done.
Yeah.
So I was quite entertained by how much has been done.
Yeah, thank you, Councillor Fenton-Glynn. It is interesting how I think progress is being made. I think the one most important element is actually the communication between the different organisations, and certainly even as a board ourselves, we're actually now speaking on a regular basis with the adult safeguarding boards. And I think that's real key, so that actually we're talking to all the other agencies as well, so we're equally updated accordingly. So I'll bring in Councillor Hutchinson at this stage. I've got a list of people now, so Councillor Hutchinson, please.
Thank you, Chair. When the draft report came before this committee earlier on, one of the key observations was that these people don't fit into the system. I mean, they don't fit into the community in general, which is part of the reason why they're in the position that they are, but that they're trying to interact with a very inflexible system, so that actually thinking about healthcare, getting appointments to them is problematic. If appointments are changed, notifying them of that. If they don't turn up for the appointment, then a lot of the systems just drop them completely and say they failed to attend, no further action. And a complete lack of professional curiosity as to why somebody may not have attended for an appointment, and looking for the result, looking for the reasons behind that. I can't really see from the action plan how the new system will make sure that people do not disappear, fall out of view. and get lost from services. Will the MDT that's being set up keep track of them all? As we've said, the numbers of people involved are not very great. Similarly, I believe that it's not unusual for people who lead a street-based life to actually move from area to area. So are there going to be facilities for such records as there are of them to pass to equivalent bodies, equivalent areas, layers of the organisation in other areas? So I'd like to, on the electronic patient record systems that are in place so much, is there going to be some kind of notification that this is a person who leads a street-based life, so that decisions on whether to follow them up or not can be taken in the light of that understanding? It's really the way that people get lost from the support services that bothers me.
Thank you, Councillor Hutchinson. Who would like to answer that?
I can assist. Sorry, I can't find my hand for some reason. My apologies. It's Sean again. Hello.
That's okay. That's fine.
Sorry about that. One of the things that is a running theme that isn't in the report necessarily, or necessarily in the action plan that, as Councillor Hutchinson had outlined, which is actually being currently updated, is the need, and it's a constant conversation now, and I think I used the word 2 or 3 times when I was outlining the report, the need for services to be agile, and to be agile in the way where professionals are professionally curious, because clearly that wasn't the case previously. We still have a hell of a lot of work to do to get there, but there really is now that sense across all agencies as far as the strategic work that we're doing, but equally importantly, the operational work, to make sure that we've got that buy-in and to make sure that there's a simplicity. So if I can use an example, it would be making sure that as and when the person engages, they have a person, a community navigator, as we might be calling it, that is their touchstone, their touch point. So that if they fall out of the system or we can't see them for 2 or 3 weeks, they know who to contact or when to contact or where to go. So we're trying to build that kind of system whereby if they wanted some advice from mental health services or adult social care, they could get that as and when they re-present. Secondly, as far as Councillor Hutchinson's point about electronic file recording and trying to ensure that people their file records are kind of transferred to other areas. One of the things that we're looking at when we're developing, or as we've been developing the integrated single approach, is a very kind of simple multidisciplinary case file recording system. It's a kind of miniature version of what we use in adult social care that has interoperability with EPR and also our own system within adult social care and RIO in mental health. So we are looking at that. What we haven't got or thought through yet is how that would work regionally, but certainly locally.
Yeah, thank you, Sean. Just for everyone's information, the raised hand is actually now under reactions at the bottom screen on the right-hand side. You can see it there. I did struggle myself for a few moments and I found it, so just for everyone's information. So, Councillor Parsons-Halls, please.
Thank you, Chair. Yeah, I'm on an iPad and I have to touch the screen and go under More, and at the bottom of the More section is the hand, if anybody else is using the iPad. Okay, so a couple of things, a couple of comments and some questions. So one of the comments, so I was reading the report and I think one of the things that was said, we used the term creative intervention. In my profession, creative intervention is creative arts therapies. So I would appreciate if we could just put a range of interventions rather than a range of creative interventions, because it could be slightly misleading if we're going to use creative arts therapies, for example. That's just a comment, really. So if we look at the COVID shelter, we were so 57.3 has been reported as having a mental health need percentage. I'm presuming these are self-referred, as opposed, because then you go on to say it's 44% had a formal diagnosis. And the correlation, I just found it quite alarming that there's 80% of residents reported substance misuse. Now, from my understanding, people don't get into substance misuse unless there's a mental health issue. So I'm wondering, obviously, we can't go around diagnosing people unless A, they want to be diagnosed, or B, they are in position to be diagnosed. So I'm just looking at that as long as we're all aware that that is actually the reality, there is a bigger mental health story here. Obviously, I'm new to this panel, so I haven't got the background, but I'm understanding that everybody's aware that people have complex needs. And then, Sean, you mentioned looking at a trauma-informed intervention. I was wondering, can you give us a little bit more information of what that trauma-informed intervention is? Obviously, you're looking at research and some sort of practice model, as you explained. Can you expand a little bit on that for us? Yeah. Thank you.
Yeah, if I can bring Sean in, I'm quite intrigued to hear from the CCG, because I know, unfortunately, for whatever reason, you were unable to attend our previous meeting, which the panel were quite disappointed with. So, Sean, if you'd like to answer some of Councillor Parsons-Hulst's questions, then we'll move on to the CCG to get their view of this as well.
Yeah, I'm going to defer to Niamh, because she has been, if she's on the call, she has been working on this area in terms of how we're going to develop this and how it's been reported to the Health and Wellbeing Board. So if Niamh is on the call.
She is indeed, and I welcome Niamh, and my apologies for your pronunciation. So that's my sincere apologies. It looks, yeah. So
that's fine. I'm so used to it. Thank you. Well, a few things really, just to kind of scale up. I think to respond to Megan, I think Megan makes a good point there in terms of our response to this. And just to reinforce, this isn't a health and social care issue. It's a really big issue that involves the whole system. So it is important that we take this work to the Community Safety Partnership as well, so that we can talk about enforcement responses. So I think it was a very valid point. And just a little bit on the multidisciplinary team for Colin. So Colin, the model is really, really simple. We've already had our first set of meetings where all the agencies wrap around. They have a discussion about the person we're concerned about with their consent. That discussion is focused on can do. What can we do today? And what the plan is that we allocate a lead person and we review that case within a fortnight. The idea is that we flex the system where we can at that stage. So we're looking at system change that's bottom up and top down. So I'll give you an example. So somebody might be living in absolute chaos in Union Street, be very, very vulnerable, but they don't technically fit the rough sleepers criteria to get a homelessness assessment to be accessed into accommodation. Those are things we can flex in place. So that's the idea, that we try and nudge the doors open and make those changes around the individual. And then the idea is that we do develop a really simple case management system that all those agencies can use and constantly input in, so we don't lose information and we don't lose them. The trauma is a big piece, and I think it's quite complex. I think the most important thing we want to look at first is that everybody is trauma informed. So it's not very complex training, but it's about us understanding and recognizing the trauma that these individuals have encountered, but also the impact of trauma. And then we would like to develop, with more training and more expertise, we might look at a trauma-informed service response, which is a bit more of a psychotherapeutic response. So, and then beyond that, certainly within health, there'll be much more complex trauma interventions that would be used. Is that okay?
Yeah,
thank you for that.
Yeah, Neil, do you want to come in at this stage? I know you had your hand raised previously, so perhaps you'd like the opportunity to come in at this stage.
Thank you. I've got colleagues with my as well that have more of the detail. So we have provided a sort of a detailed action plan that's been done with partners, with Sean, and colleagues. Rona leads on it from a commissioning perspective, with Emma Bonus, who's our primary care and GP commissioner, who's unfortunately on leave. Helen Davis is one of our GPs who is acting from a provider perspective in delivering the sort of service and the outreach services that we've talked about. So they've all been involved in lots of the conversations. Just to pick up on one of the points that Colin raised about sort of electronic health records, they're really difficult to put flags on. So particularly flags that could seem to be discriminating in any way have to be really careful in primary care. So we have summary care records that if someone is out of area, that's able to pick up their key if there are mental health or health issues that people, if they need treatments outside of Calderdale, would be able to pick up. But it's very difficult and against a lot of IG regulations to put a lot of other flags on. That's not to say that there isn't a lot of work nationally going on with social care to tie in access to health and social care records. And it's a bit of work that's being done across sort of Calderdale with the hospital and primary care in Calderdale. So I'll sort of let my colleague Rona, who's more closer to the detail, to sort of speak and answer any questions if there are anything on the action plan, if that's okay, Councillor.
Yeah, no, thank you for that. So Rona, do you want to come in at this stage, or do you want to, yeah.
Yeah, I can just give an overview, and then if people have got any specific questions. So similar to what Neve has already said, we do see this as a system review and a system plan, but we are aware that there's a responsibility, although for all partners, there are some specific areas that relate to health, and as a CCG, we have created an action plan. I chair the CCG internal group, which, as Neil has said, has got Emma Bonus from primary care and Luke Turnbull from safeguarding, and our quality team are involved, as are our contracting team. So we are taking this seriously. We have produced a plan, and we have got some actions and some timeframes of when we need to complete the action and the action log. We've taken the plan through our Quality Finance and Performance Committee, and they have agreed to be the oversight for this, the assurance that the actions will be achieved. And we've taken it into our senior management team in the CCG. So in our governance, we are having full governance assurance on this and sightedness. It's going into our governing body meeting this month as well.
Excellent, thank you, Rona, for that. So I'll move on to Councillor Barnes, please.
Thank you, Chair. I've got some specific questions or questions on the report itself, but I don't want to start with that. I actually want to turn this on its head. And it's great that we have processes. It's great that we have procedures in place. But actually, what about the users? What about the individuals that are in need? What have they seen? What changes have they seen? It's great that we have a multi-operational team and 25 people who meet every 2 weeks about it. But actually, let's look at those individuals on the street and what have they seen? What changes have they seen? What benefits have they seen? I'm going to ask a question here and say, would you say that they are in a better position now than they were before? How do users access this? I use the word access the system. That's a very middle class, well-educated statement to say in terms of accessing the system. And I'm fairly sure, if I went to the Halifax and Homeless Kitchen on Sunday and asked those individuals, what would they say to me? And I think we need to sometimes look at it from their point of view, not just from the report point of view. So could you cover that, and I'll come back to the other points later if we have time. Okay.
Neve, you look like you've unmuted yourself, so please.
Neve is front and centre on my screen, so I saw that as well.
What would I say? First thing I'd say, Councillor Barnes, is that the 8 people that are in the new unit have obviously immediately benefited in terms of safety. I wish I could show you. I have a little selection. I send them to Debs when I'm feeling a bit glum about work, of people living in madness and chaos that we can get in to bake a cake, that we can get to mow a lawn, that we're talking to them, that we're outreaching them, that our services have become much more flexible at working with people during that period of change, and that we certainly We're delivering sausage butties down to our hotspots twice a week, along with naloxone and needle exchange, and we're doing an awful lot of engagement work. I do think, well, I mean, it'd be really interesting to find a way of giving you some feedback. I'd quite like to think about that, because their voices are very present, and without their voices, none of this will work.
Cool, thank you, Niamh. Rona, you've raised your hand.
Sorry, Chair. Sorry, one thing about that. I don't know whether this was Niamh or Rona, but how would they get into the system in the first place?
We look for them. We look for them. So we've got street reach outreach workers that will respond to intelligence or phone calls, particularly if it's out of the town centre and somebody thinks somebody's, in a caravan up in Todd or whatever. Or we look for people on the streets and we know where to find them.
In Todd, but okay.
We kind of know the difference.
Excellent. Just before I bring Rona in, do you liaise with street angels as well? They're very active in the nightlife of the local towns.
Sorry, yeah, street angels, community safety wardens are fantastic. In fact, they've been coming to our MDTs because if somebody is still sleeping out, we know where they are. We can ask the wardens to check on them. They do welfare work for us around having that 24/7 ability.
Is that effective communication, people working together across organisations? Right. Yeah,
everybody in the room, yeah.
Yeah. Rona, would you like to come in, please?
Yes, thank you. I was just going to respond to Councillor Barnes. There is a piece of engagement that is being undertaken by Groundswell across Calderdale, Kirklees and Wakefield, and it's exactly to do what you're asking, is to get some of that information from the individuals. They've done this in other places. We're expecting the report back at the end of this month. So hopefully we'll have something that we can share. I think it's a draft report at the end of this month, but we'll have something that we can share with people. But it's exactly that point, is how do we get the views and how do we understand that view from the individual, the homeless person themselves. So it's to get their voices about experiencing homelessness, but also to get the outcome and the learning that can help us inform our action going forward and can help us with that decision making of what we need to do next. So we can share that with members once we've received that.
That sounds an excellent proposal. Neil, I'll bring Neil, then Sean. So Neil, please, yeah.
Thank you, Chair. It's just sort of build on what Niamh and Rona says. I think a practical example is the level of priority this group has had sort of during the pandemic. So the gathering place and the street sort of based living people were one of our priorities for our first pop-up centres for the COVID vaccination programme. So we did them in Calderdale above everyone nationally and above sort of outside of the JCVI guidance because we recognise them as a priority. We couldn't have done that and got the coverage that we did without working with Niamh and her teams and other organisations to get the numbers to that single sort of place to ensure that we had that extra protection. So it's really raised its sort of profile in service working, and I think we've got practical examples of where we are seeing the benefit of them, and I think you'd want them to be in the system, Councillor Barnes, without them knowing them in the system, and I think that's what Niamh is sort of explaining. There's so many touch points and they're being seen and dealt with in different ways without them knowing, but they're getting a lot more support.
Thank you, Neil. Sean, would you like to come back in?
Yeah, sorry, my apologies. I put a thumbs up when I was looking for a hand, so apologies for earlier on.
That's okay, that's fine.
I don't know my Zoom as well as my Teams. Just to add, and apologies for the jargon, and it's not meant to be, but the key aspect of the work that we're doing that has been brought to Calderdale by the Making Every Adult Matters pilot work is changing futures. And it's co-productive. So it's actually working with people that have experiences such as this that we can bring into the discussions to work with the people that we're working directly with now or trying to do that. But just to add to Councillor Barnes's point, we are working with people who have such deep-seated trauma over so many years that they find it difficult to express or present themselves. And it is one of the biggest, if not the biggest problem for us to do in terms of making sure that we can positively engage and then get some feedback from them would be something in itself. But I could only support what Neil has said in that sense.
Thank you, Sean. I'll bring Councillor Hutchinson back in, please.
Thank you, Chair. In the action plan, there's key people associated with each action, and for a lot of them there is a time scale for those actions to be delivered. But when we get to mental health services, like the dual diagnosis service for people with intellectual disability, and the harm reduction service, there is no date for action to be completed. When it says how will this, under evidence of progress, it's how will this be reviewed, what's the expected impact, etc., etc. You know, at what stage is the involvement of the mental health services at and commissioning of those services for this group, where it really is integral to their care?
Excellent. Who would like to come? Neil, you've got your hand up. Is it from last time? No, Rona, sorry, would you like to come back in this, please? Yeah, please.
Sorry, it would take me longer to find the other hand. It was easier to do that.
Yeah, no, that's fine. I saw you.
Yeah, so I've got a lead, and I'm sorry if it's not on the version that you've got in front of you of our action plan, but the lead for the dual diagnosis work is sat with myself. It won't be down to myself. It'll be a team approach with other partners. I've had conversations with the chief exec at the South West Yorkshire Mental Health Trust to look at how do we do this a bit differently? How do we take a different approach to this? What's the commitment? And what's their commitment in supporting this, and how do we start to work in different, looking at this differently, I suppose. So that's why the timeline or timeframe isn't included in the report. We agreed with our Quality, Finance and Performance Committee that I would add that in once I'd received a response from the group, because the first bit was to actually go out and do a bit of scoping and a bit of a conversation with key partners. We totally agree it's essential we do this, but we need to look at it differently. We need to take a different approach, and there are some good examples across the country that we want to look at and see how they could be maybe implemented in Calderdale as well. So I will update the version and add that in and resend that, so you've got that, Councillor Hutchinson.
Yes, it's just, Chair, that these events were 2.5 years ago. Do we have an assurance that the mental health services will be fully brought into this before the coming winter?
Yes, mental health services will be brought into this. It's part of the whole action plan, and the national long-term plan is that mental health support for homeless people should be in place. So there should be services in place for this cohort. So that's the conversation I'm having with them. So there is assurance that they will be brought in. And they will be involved in this.
Yeah, thank you for that confirmation. I think we all need to know that. Councillor Megan Swift, then I've got Councillor Parsons-Hulse. So Councillor Megan Swift, if you'd like to, there we go, you were muted.
Yeah, I mean, I've sat listening to you all, and if I'd known just about a fifth of what I know now, I wouldn't actually have been as worried as I have been, because, you know, being very genuine about this. That first report when it came here was frightening, but you know, and I should imagine most of Scrutiny don't recognise everything that's been going on. But please, Council, CCG, anyone else, please keep each other informed so that we know and we don't have to get into a state about it.
Yeah, thank you, Councillor. Thank you, Councillor Swift. I think by us setting up regular meetings with all the different organisations on a regular basis, and having regular meetings with the portfolio holder, Councillor Fenton Glynn, I think it basically keeps us better informed, and everyone making sure that they're speaking together and communicating. So, Councillor Parsons-Hulse, please.
Thank you, Chair. Yeah, it's really encouraging to hear that, Rona, that you're looking at lots of different models across the country. I think you know, a lot of these people have attachment disorders, and you know, the first thing to do is reject. You know, they project onto the, we are perceived to be the parent, if you like. So that's going to be the projection. So I find it, you know, it's great that you're looking at different models, because mainstream mental health services, as you pointed out, is not necessarily going to fit this client group. You know, building trust is very difficult with this client group. So, and Niamh, sorry, you're nailing it. You're absolutely nailing it. It's got to be done under the radar. You've got to build that trust. It's simple things like the cake baking, all that sort of stuff. It's the relationship building that is going to enable you to do the mental health work, because you can't just go mental health services. It ain't going to work, which is probably why it's not worked, or maybe it's not worked in the past. So I'm really excited to see that we're going to look at different models that other people are trying out as well around the country. So yeah, be looking forward to hear about that. Thank you, Chair.
Excellent. No, thank you for that. And Councillor Barnes, please.
Thank you, Chair. I think my specific questions in regards to the report might hopefully be answered when Rona sends us the updated version. I think a couple of things. One, I would like this to be brought back again to scrutiny at a future date to see where we are against those steps. Probably worth us looking at the action plan and identifying a sort of key point when a lot of those actions have been undertaken. I think there's a point as well here, which is the lessons that we're going to learn on this, because this is very much based on street-based lives, but we have a large number of people who are on the cusp, who sit in that neglected area, who might have a home at the moment, might be subject to eviction, might be very much in danger of falling into this. And really, you know, are we therefore looking at this as a sort of model that we can then expand and move out into those other individuals? Because the people aren't going to get, you know, people who face trauma, people who have fear of the system because of those trauma, because of those, they feel they've been let down, aren't just living at home, aren't just living on the street. Some of them are living at home. Some of them are living with other people. And I just wonder what we're doing about that, and are we widening that approach? I can see Niamh again, front and centre on my screen, nodding. So I expect Niamh is going to answer this.
She is indeed, absolutely.
We are widening the approach. We're very conscious of that. I mean, one of the men that died had been very recently evicted. So we're working with Together Housing to look at how we identify those vulnerable groups within their big, large housing cohort, and what tenancy sustainment and support we can put in as early as possible. But I think you're absolutely right as well, Councillor Barnes. I do believe if we get our services right for the most difficult to engage with and access, we're going to improve it for everybody. You know, it will just be easier for everybody.
Indeed, totally agree. So really, I guess to conclude, we do want the report. We do want a report coming back, and it's about the preventative work actually that's taking place. I know Children's Services puts an awful lot of money into preventative work, so that young people don't go into care. Equally, if we invest, we'll save money, I guess, in some ways. We equally want to speak up on the action plan itself as well, so bring it back in terms of what's happening with the action plan, and equally the views from the individual as well. So if we bring all of those and culminate them together, and we'll put them onto the work programme. So I very much appreciate everyone attending, giving us some assurances, and actually things will improve, and preventative work will begin to protect individuals that are very vulnerable. And we don't want to see a report of this type come into the panel. I'm sure nobody does. So thank you for your attendance, those for this particular item. We now go on to item number 6, which is access to general practice and update. The Chief Operating Officer Calderdale Clinical Commissioning Group. So the report has been circulated. This is really, I guess, in some ways, it's what we're hearing as councillors, is what we're hearing in terms of from the public perspective. What's actually happening in the background may well be different. So, Debbie, are you leading on this? So, welcome to the meeting, by the way.
Thank you. Okay. So, just by way, so you've been provided with a report that provides an update on access to general practice in the context of the pandemic and the ongoing challenges. I don't intend to go through the report in detail, but would like to pull out a few key points. So those are that the report does provide assurance that general practice in Calderdale has remained open throughout the pandemic. It highlights that the key difference has been the accelerated delivery of remote and virtual services. This step was taken to reduce the spread of COVID, and practices were required to introduce a total triage approach, or practice introduced telephone triage, which meant that patients are assessed by a clinician over the telephone in the first instance. In terms of the context, the report highlights the introduction by NHS England of a standard operating procedure for general practice in England, and this continues to be updated as guidance changes, and it does remain in place. The report highlights the significant input that general practices have had in respect of delivery of the COVID vaccination programme in Calderdale whilst maintaining access. It provides information relating to appointment data and types of appointment, which is a national data set that is still being refined. Section 3 goes on to provide a summary of the activities that are ongoing or further planned to support access in general practice in Calderdale. We do recognise that there is still further work to do. And finally, I just want to advise that this conversation is being supported by the CCG's clinical lead for primary care, Dr. Majid Azeb, the chair of the local medical committee, Dr. Seema Nagpal, and the LMC's director of operations, Mr. Marcus Beecham. So at this point, I will hand back to the chair for questions.
Yeah, thank you for the update. As I say, I think it's the perception of questions we're being gaining through the emails. I was somewhat disappointed in the response I got from the Topperton practice manager. It was a very polite email I sent, and I almost got a shouty one back. I'll copy you in because it was of concern as to the response I actually got. It wasn't raising anything nastily. It's just comments we get back. So I'll bring in Councillor Barnes, and I've got Councillor Hutchinson and Councillor Swift. So Councillor Barnes, please.
Thank you, Chair, and I think I would like to echo a couple of points that you said. Firstly, in regard to practice managers, I've also had quite a condescending and patronising emails from practice managers in the past when I've raised issues with them, which is basically throwing it straight back without actually addressing the issue in itself. I think the view here, and regardless of what it says in the report, is the perception of Calderdale residents is completely at odds with the data in the report. And that is, I think, all 51 councillors would point to casework and correspondence to that effect. Okay, and I think that's the key thing there, is that the perception is that you were closed. The perception is that you wanted to move to telephone and non-face-to-face appointments.
Yeah.
Including individuals, including people of a certain age who didn't have the appropriate technology to be able to do so. I know a number of residents who don't have smartphones. In fact, they've got pay-as-you-go phones, which actually probably have better battery life than most smartphones, to be honest with you. The old Nokia 6110. Sorry, there are other mobile phones available who don't have it. Who's the first thing? I have instances of individuals saying that when they rang up, it wasn't the clinician who interrogated, this are residents' words, interrogated them over their symptoms, but it was the receptionist. When eventually, after 2 hours, they got to speak to a receptionist. Now, that might not have been a receptionist. The receptionist might have been a practice nurse. It might have been a clinician. It might have been. But the feeling that when you are wanting to talk about maybe some sensitive issues, to have somebody who you don't know over the telephone start asking you about those sensitive issues and not putting you through or not referring you until they got the answers that they wanted on their tick sheet. This is the perception that residents have. And this is what all of us have experienced over the last 12 months. Okay. And I think that's why we wanted this to be brought back to this. So, for example, were any mystery shopper, you say this was done. Did anybody do any phone calls? Well, did anybody ring? Did anybody from the CCG, did anybody from that ring up? Was there any mystery shoppers done to identify whether GP practices were doing what they were meant to be doing?
Absolutely.
Okay, was anything like that? do we have any breakdown of the data that you've put on here per GP surgeries and the number of GPs that are at that surgeries? Do we know how many people hung up and didn't go through, and in the end went to A&E, possibly when they shouldn't have done, and put extra pressure on the A&E services? Fully understand and appreciate that the GP practices had to ensure that they were COVID safe for their staff and also patients. But this is the sort of feedback that all of us have had over this last 12 months. Thank you, Chair.
Thank you. Debbie, do you want to come in on this one?
So I think in the first instance, in relation to Mystery Shopper, where we've had information suggesting that there are issues with telephone access at specific practices, we have addressed that. So I don't want to work in generals that everybody was, but we know we've had specific challenges that we have addressed. We have got GPs on here. They may want to respond. I couldn't keep up with how many questions there were, to be honest. So mystery shoppers, yes, but not routinely, because that wasn't the information.
I think the other questions were based about the breakdown. So you've got a great chart here which shows face-to-face, telephone, video upon home visits and what have you. But do we have this breakdown per GPs, per practices?
So, unless we were able to ask the practices to provide it, the answer to that is no, because the data provided to us by NHS Digital on behalf of NHS England is only at CCG level at this stage. Ideally, we want to be able to get to more information, and the other information that is not available is the access that is provided at scale. That data is not included in that chart. So the people that the physios and the care navigators and the prescribing pharmacists that are providing services at PCN level are not, that data is not included. So it doesn't show the full access as well.
Yeah,
so nationally, it's England at CCG level.
Okay, I'm going to bring in Majid, please. If you put your hand up, so I'll bring you in at this appropriate time, if that's okay.
Absolutely, thank you. So I'd like to say thank you, Councillor Barnes, for all the concerns, and I appreciate that lots of people have been hearing this. Of course, I'm sure we'd want to start with kind of thanking the health system generally and the general practice as it stands for kind of managing the situation and keeping the country as safe as we could, while all the while, of course, as you've seen in the report, delivering the vaccination service as well, which we've done, and we've done actually probably a lot better than most of the country, or certainly at speed that we did it at. Yet all the practices have been providing it. I think we need support, and this is probably one of my pleas, is bringing people up to speed, and actually it's the communication. So I don't know, had yourselves had this report at an earlier date showing all the mandatory changes we had to make around the NHS England SOP and the telephone triage. Answering a specific point, Councillor Barnes, the bit about somebody having to tell the receptionist what it's about. Now, they certainly shouldn't feel interrogated, of course they shouldn't, but actually we have so many different clinicians now, whether that be a first contact physiotherapist, whether it be pharmacists, practitioners in nursing or pharmacy or social prescribers, care coordinators. We do need our receptionists to get at least an indication of what the problem is so they can actually put the person with the correct clinician as a start. So I think that might be what you're alluding to, or what the person that was concerned. But of course, there's lots of work to be done still. I think if you look at the charts, you'll see that the March figures on the charts are showing, since NHS Digital started gathering figures, that it's been the highest number of appointments delivered in Calderdale since the records began. So actually, even from pre-COVID, as far as appointments are concerned. And 55% of those appointments, 55% of those appointments have been face-to-face. So I think we've got a big issue with perception compared to what's actually gone on in reality. And I think the other major thing which people kind of get and don't get is what general practice used to do and what it does now. So yes, absolutely, people used to get through on the phone and get through on the phone easier, but it wasn't ever easy, I don't think. But they might have had a routine appointment in 2 weeks' time. Now that's flipped on its head. So 95% of people who ring have a call back at least the same day, if not that morning or that afternoon. And the routine appointments, which might take up to 2 weeks, are actually fewer in number. So the responsiveness of general practice has changed significantly. And actually, there's, as always, a large number of people who actually like the changes that have occurred, but you don't hear about them, of course. So people like the convenience of telephones, being able to ring up and say, I don't need to come in, I need my sick note, I need you to sort my prescription. And actually, there's also significant feedback, I think, of people liking it. The bit about, well, what are we doing about the phones? Lots of practices have now invested in, and the CCG has supported them in this, newer phone lines, the internet-based ones, the ones that do exactly what Councillor Barnes is saying, which is counting the number of calls in, the number of calls waiting, the number of calls abandoned. And they're looking at that data actively, certainly in the central PCN area. They have, and we've seen evidence of this when we have been to certain specific practices from concerns raised, told us about the increase in employment in staff, whether that be reception or admin, and they've also increased clinical staff to manage this. As well as that, of course, remember, and I appreciate, again, not everybody can use it, but it has been a national push and drive to use online and digital technology. So I think I'll stop there. There's lots more to go on about, but I want to give other people a chance.
Majid, thank you for that information. I think there's one point that clearly comes out of this. We're not doubting the amount of work that you're doing. We appreciate everything that the NHS and doctors are doing. It's a perception that we're saying we are your critical friends. So we're communicating back into what we're hearing back from the public. What we want to do is actually probably from this meeting is commission how we deal with communication, because I think it's the communication that's been ineffective actually to the general public. And I think this is the key that's coming out from what you're saying. You're saying you're doing all these wonderful things. That's brilliant, absolutely brilliant. But actually, it's not what the general public are. It's not what it's the perception. It's not what they're understanding and the way it's going forward. So from this, one of the action points is to commission a report on how we communicate what you're doing in the future to ensure that actually Joe Blogg's down the street that doesn't have technology, how does he access a GP surgery? How does he get in to see you to get the best possible healthcare? Because we know you do provide it, but so actually we are your critical friend. We want to help you, and that's what we're feeding into you at this moment in time. So I'm going to bring in.
Chair, can I just come back on that one really, which is just the fact that, and this is, perception becomes reality. And you've then got a much harder task of saying people actually your perception was wrong in the first place, because they've got it into their mind that their perception is the reality across the piece. And absolutely, I'm all for technology. When I worked in Leeds, a phone call would have been a much more better system than having to take a day off work to do a routine appointment. Absolutely. And I think just want to echo that, and that's the issue there, is that it's become people's reality, and that hasn't been diffused in any way. Okay.
Yeah, no, thank you. Neil, you've had your hand up. Would you like to come in at this stage, please?
Thank you, Chair. Just sort of build on Madge's sort of comments there, really, and hopefully Ian will sort of support me. I think part of the communication has to be about the unparalleled level of demand and asks that we're seeing on all on health and social care. So Madge has said about the level of capacity. We've got a finite level of resource to deliver health services. At the height of the pandemic, we're very good about protecting our hospitals and whatever. We're now seeing that level of demand across all health and social care demands. Calls to 111, to 999, to GP surgeries, the attendance is A&E, plus trying to deliver our backlogs of care. There aren't enough people to deliver everything. So there's something about not trying to not trying to change people's perceptions, but to help manage expectations of what can and can't happen, and to use the best thing. So we have done a lot of work with A&E about, I can't see a GP, I go to A&E. That isn't the case. We've done a lot of work to actually, the majority of people go to A&E because they want to go to A&E. And we've got systems in place. If it's a primary care need, they book an appointment back at their GP.
Yeah.
So it's not that you can't see your GP that you go into A&E. It's just demand. We've got to talk as a system, as part of that commissioning piece, of what can people's expectations be, because there's a lot of low-level demand, self-care, things that can be done through pharmacies, that we've done a lot of communications through various mediums, through newspapers, through social media in the last 12 to 18 months, but it somehow doesn't have an impact. Well, the demand keeps growing. Yeah, that's what we need help with the managing expectations, because it's a finite resource.
There is, Neil, I fully understand that, but we have a chief executive that's on the CCG panel, and we have a communications team within Calderdale. So actually, in terms of the resources, there is some additional resources that are not being used, I think, in terms of it. This is what I'm saying. This is what I want to build on tonight, is a report in terms of the communication, because it is not working. It's not working for the general people out there. Yes, there is a higher demand, but equally they need to know that when they can knock on a doctor's door, that they can actually physically see somebody that they need to see. So I will say that actually you can report this to the chief executive in terms of any issues in terms of what you feel communication you feel is not working. So joint effort between Calderdale and the CCG to ensure that actually there is effective communication. And this is, I say, we are your critical firm. We're not having a go at you. It's just purely what we're receiving via our emails on a daily basis. So thank you for that. I'll bring in Councillor Hutchinson at this stage, please.
Thank you, Chair. We are likely to be in a position where the principal means of contact with primary care services is by telephone for some considerable time to come. That being the case, it's vital that we have the correct capacity of telephone lines and people to answer the phone, so that people aren't left hanging on for 40 minutes, an hour, waiting to actually get through, with no message to say you are number so-and-so in the queue, so they can then make a decision as to whether to try again another time or hang on for a little while longer. We really must get the telephone infrastructure in the practices right for the purpose that's required. I do not know whether that is the responsibility of the individual practices, or whether this is something that can be coordinated at PC primary care network level or at CCG level. But someone somewhere needs to get a grip on this, because that is one of the principal issues. In the figures that you've given, I'm very surprised that there's a negligible level of video consultation going on. Lots of telephone consultation, but video consultation doesn't seem to show up at all on those figures. Is this something? Is that because it's been tried and found to, not be terribly a good way of actually delivering services in the current situation? But I do want to link into the revised standard operating practices under which primary care has been working since May. On page 25 of those, where it talks about referral numbers for some cancers remaining lower, including common cancers such as lung, prostate, urology, skin cancers, including melanoma. Isn't this an inevitable consequence of diagnosis over the phone? We heard from the local Cancer Alliance that this was a problem last year compared to previously. I'm really concerned that that we're only picking up a certain amount of information by relying so much on telephone consultations.
Neil, would you like to come in on this? You've got your hand raised, so hopefully you might be able to help on this.
I'm looking. Oh.
So Neil, you're on mute. I'm sorry. Yeah.
Sorry, I'll
That's
try and cover all the questions if I can remember them. So apologies, Colin. So the one about the telephones, that is an independent GP practice requirement. However, we do work collaboratively with our primary care networks and with the LMC to encourage people to work at scale where possible. But it's you can't commission them to do it. So we've had numerous conversations over the years, and as Madge highlighted, there has been investment in upgrading telephone systems to do that. I think with regards to the perception that it's all on telephone, I think Debbie alluded to earlier that we do video conferences, and that is probably one of the things that's not collected by NHS Digital as to a means of doing it. The difficulty with the video conferences is people have to log that issue through the website, and that's probably one of the areas we'd like to sort of promote, that you can do online consultations that can end in a video consult rather than a telephone thing. I think there is a thing we need to work on, that GPs are not just seeing people by telephone. I think Debbie alluded 55% are still face-to-face. And then there's still a certain amount of telephone triage and redirection and use of other people like physios and social prescribers. So it isn't just all by telephone, and there are a lot done face-to-face where need. Telephone and video conferencing is sort of here to stay for all health, not just primary care. So it's a big push within secondary care. But on the last bit around sort of diagnosis, probably need a clinical colleague to come in on that. But that's not something that we're hearing or is a quality concern that's coming through our sort of quality surveillance group with practices. But that may be something our clinical colleagues can allude to more. Hope that answers a few.
Yeah, thank you, Neil. I'm going to bring in Dr. Nagpal, please, and welcome to the meeting, of course. You just on mute, I'm afraid, so that's better.
This is my first scrutiny, so yeah, thank you for inviting me. What I don't want to do is to be the defensive GP on this side. So you've got me at the end of the day. I started at 8:15 this morning and I finished at 6:30 in time to make this meeting. So you've got me at the end of a long day. But what I wanted to say is, from the patient side, I can see where they're coming from. You know, they were used to good old-fashioned general practice. I mean, I've been a GP for 30 years. I used to love seeing my patients face-to-face. I used to love the continuity of care. I loved knowing the fact that I knew who's had their baby and watching the children grow up and themselves becoming parents. And that is, I think, the general practice that a lot of us remember and a lot of us would want. The sadness for me as a GP is that that isn't what general practice is anymore, because it's changed. It's changed just because the way we practice medicine's changed, how we're asked to practice by NHS England has changed, and general practice isn't going to go back to what I used to really love and what the patients did. I sort of come a bit from a contractual head, so I want to take away the word telephone triage, because it's not telephone triage, it's telephone consultation. It might be triage at the point where a patient speaks to the receptionist and gives the details. And if there are issues about how they're being asked for the details, which they never did in the old days, that's a different issue. We should be looking at that in training. But after that, it's a telephone consultation with whichever healthcare professional they come in contact with. The bit about the video consultations is the way videos are done is you ring a patient, and it depends how you do the video consultation. So it looks on the screen that NHS Digital pick up that it's a telephone, but within that you can send a link, something called AccuRx, and you can send the link and you can do a video, but that won't log on as a video consultation. No one will know you've done it. But the same thing comes with video, is the issue that you've got the elderly, the people who don't have smartphones, who are sitting home alone. They can't video anyway. So we've got to develop our skills to be able to pick things up on the telephone, which we always did and have done. So that's a bit of the video question, because it's that balance. But videos are great. You've got a mum who rings and says their child's unwell and wheezy, and you can video and you can see whether they're running around the room or how wheezy they are. And then you know whether it's appropriate to bring them in to a surgery, which may have other COVID patients. And it's only going to get worse for the next 3 months, easily, as we know. So that was the bit on those. And I think it's patient perception. You know, the way we used to practice general practice is no longer the same. And when we're talking about the communications, I think it's somewhere, and I'd be very interested just to be part of that, because as a patient, I can see when patients turn up and say, I can no longer see my GP, they don't count a telephone conversation as seeing their GP because they haven't seen us. And in the past, they would have seen us. And it's changing the perception that the way we manage healthcare and primary care is different. It doesn't mean it's worse, it's just that it's different.
Super. Thank you so much for that. That was honestly a breath of fresh air in so many different levels, and you know, very much appreciate the hard work that you are doing. This is the whole thing. We're not saying you're not doing anything whatsoever. We do acknowledge the hard work you were doing. We just think we want to be there to help to improve the service. So actually we very much welcome you on board as part of the communications. That's what we're after, basically. So thank you for that. Apologies to.
Excuse me, Chair. I mean, I did what I said about referral numbers for cancers doesn't come from me. It comes from NHS England in May this year, saying that referral numbers were low, particularly for specific cancers. And I just, you know, I'm not sure that whether that is actually being perceived as a potential problem in this area with the way that services are operating now.
I'll bring in Neil, then I'll bring in Majid, and then we've got Councillor Megan Swift, then Councillor Kingston. So apologies for the wait, but it's really important that we get the opportunity to, whilst we're all us face to face. So Neil, please.
Sorry for missing that bit, Colin. So yes, NHS England raised issues, and part of its annual planning process raised cancer diagnostic and referrals as a priority area. And across Calderdale and across sort of West Yorkshire, we've been one of the top performers for maintaining our levels of referrals and maintaining our levels of treatment. That's come from work from our cancer network. So we're not an outlier on that at all. So whilst there have been some areas where there's been a real drop across Calderdale, and particularly with our acute trust, it's been our #1 priority to ensure that continual treatment and seeing of patients for cancer.
That's good to hear. Thank you.
So, thank you. Majid, would you like to come back in, please?
Yeah, thank you. I think Neil's pretty much summed it up. However, I think just generally in across West Yorkshire, the referrals for cancer, not just this year and not during COVID, has, you know, that's been a cause for concern. Depending on who you talk to, it has been, you know, we need to refer more and pick up cancers at an earlier stage. So the concerns are very valid, and I think it's excellent to keep a close eye on it, especially when models are changing and how we're doing it. But like Neil said, I don't think we've seen any particular or significant drop off in Calderdale, but actually I think generally we need to increase and do better at that, full stop.
Thank you for that. Councillor Megan Swift.
Thank you, Chair. I can't see mute or not mute.
We can hear you, so continue with your question.
Yeah, I mean, this mistake was made right at the beginning. When people did what they had to do because it was a crisis, they didn't think about taking anybody with them at that point. Probably because we all thought it was going to be about a month long. But I mean, I've had some dreadful phone calls from people crying. I've been trying to ring all day and blah, blah, blah. And I didn't believe one lady, if I be honest about it. So I went and sat with her. And she had tried, and she tried, and it just didn't get anywhere. Now, personally, I've been really lucky with our doctors. I'd still rather we didn't have to use a phone, but I mean, in fairness to them, yeah, they've been all right. But when Mrs. Jones down the road at 76 has to go to Queen's Road surgery, something or other, it's 2 buses there and it's 2 buses back. And nobody seems to take that sort of thing into account. You know, everybody hasn't got somebody with a car or even a computer. I think the thing that I would like, and I think it's impossible, if the IT surgery had, where we seem to be moving around all surgeries, it would be really good if they had the same IT. So if somebody wasn't very IT literate, you know, it doesn't matter whether they go on Queen's Road or the Boulevard or what, you do it in the same way. And that hasn't gone.
Yeah, no, thank you, Councillor Swift. I think so some of those comments will be looked into. Councillor Kingston, welcome, and your first meeting, so welcome, and please go ahead.
Thank you very much, Councillor Blackburn. Just coming back to the telephone thing, thank you, Councillor Hutchinson, because you said everything that I was wanting to say pretty much, except that I just wondered about targets and data. I see, thank you for telling us that there's an independent GP practice requirement around answering telephone. I'm thinking about when I go to my GP surgery, there's like a notice on the wall that tells me how many doctor's appointments have been missed in the previous month. You know, a little guilt trip for people about not turning up to their appointments, which is great. But what about turning that on its head and having a requirement for GP surgeries about how long it takes to speak to a live person at the practice? So 95% of telephone calls received are answered by a live person within 5 minutes or something like that. Some kind of data requirement around it, a target, a time requirement with a target, with data actually reported to the public, so that there's pressures on GP surgeries to actually put better systems into place for getting calls answered. I know it's not happening. Just during the last week, I rang a GP surgery in Skirker on behalf of a resident, and I can't believe the amount of time I had to stay on the phone in order just to get through to a receptionist. It was ridiculous. And I would imagine that most people would have given up. I was just particularly persistent. Thank you.
No, thank you for that. I think it's echoing a lot of what a lot of the councillors are hearing and officials. So I think it is something that is very valid. So thank you. I would like to thank you for attending this meeting. I hope you don't go away upset and feeling hurt, because that's not the intention. The intention is to actually help to ensure that actually we can help you. Provide you with an excellent service that you're doing, but actually improve the communication element, I think. So from this, I would like to recommend that we commission a report in terms of how communication moving forward is dealt with, and very much would appreciate the input of Dr. Nagpal and anybody else wishing to input into the system. So if members are happy with that, I will close this item. So thank you, members, for that. We now go on to item number 7, which is Oral Health Strategy and Action Plan. And this is an oral report from the Director of Public Health. Just for anybody who's finished their items that needs to go, then please feel free to do so. So who's reporting on this? Sorry. Debs. I'm looking for Debs.
I'm struggling to get off mute, Councillor Bragg.
Oh no, that's okay. That's fine.
This is an oral update on COVID-19. Just as I do at these meetings, try and just give a brief update. Sorry, was someone?
I think Mike was trying to potentially say something, but I'm not quite sure.
Oh, sorry, Mike.
So I think we the dentistry report. That's Stefan.
Stefan, right? Okay, Stefan. Sorry, my apologies on that one. Stefan, welcome to the meeting. I can see I'm just looking all around Zoom. You're right in the middle, so there we go. So thank you, Debs, for starting this off. Stefan, would you like to give us an update on
Thank you very much, and thank you for this opportunity. I'm very happy to be here this evening. My name is Stefan Serban. I'm a specialist registrar in dental public health with Public Health England. And I think prior to the meeting, it was circulated the report that we've done, the oral health needs assessment and strategy, which is quite a comprehensive document. So we did also a bit of a 3-page briefing of the highlights. I'm not sure if it was circulated, if we sent it in time, but if I may, I will walk you a bit through that. And the main idea is really that when it comes to dentistry in the current legislative format framework, NHS dentistry is being commissioned, all primary care, secondary, tertiary, so hospital and high street NHS dentistry are all commissioned by NHS England. Oral health promotion is being commissioned by local authorities, and Public Health England is advising and supporting all these activities when it comes to oral health. So in terms of any issues around access to dentistry and so on and so forth, those are better discussed with our colleagues from NHS England. But when it comes to prevention and the prevention side of oral diseases, it's important to remember what happens before people get to see the dentist. So we are talking about shared risk factors that impact both on general health and on oral health. And some of these examples include also high sugar diets, include also inappropriate infant feeding practices, dry mouth, for example, for patients who are have chronic conditions and take medications for those conditions, giving the option of giving sugar-free medication, and of course, tobacco and alcohol consumption. Most of the data that we have when it comes to oral health is about children's oral health. So every 2 years, there is a national survey that looks at the dental disease in 5-year-old children. And every 2 years, this survey is repeated at national level. And this allows also to look back in time to see any trends in how the disease progresses, but also to compare between different regions and benchmark and see how we do. So if we look at the latest survey for 5-year-old children in Calderdale, we see that nearly 27% of them have tooth decay, which is lower than Yorkshire and the Humber, which is just over 28%, and higher than the average for England, which is 23%. When we look at the severity of the disease in those children, we see that those children who have tooth decay, by the time they are 5-year-old, they will already have 4 decayed teeth in their mouth. And if we think about it, on average, those teeth are about 3 years in their mouth, and tooth decay is completely or mostly preventable, really. So, so there's something that we could potentially do about that to prevent it. And we know also that oral diseases are not distributed equally in the population. Those who are from the most socially deprived backgrounds are most affected by tooth decay. On the next page, we've got lower tier local authority data by locality, and we see that the prevalence, the distribution of tooth decay in the same 5-year-old children varies from 17% in Calderdale and Ryburn, and it goes all the way to 38% for Central. And then on the other 2 columns, again, it's about the severity of the disease. So how many decayed tooth we see in those children who have tooth decay. When it comes to hospital extractions under general anesthesia, we see, again, inequalities in terms of socioeconomic background. And the 2019-2020 data, so before COVID, data shows that 230 children were hospitalized for tooth extractions under general anesthesia. And this is equivalent to 4 full school buses. The impact that this has on families and on the NHS is quite huge because, as we mentioned earlier, tooth decay is mostly preventable. And the hospital extractions for children between the age of 6 and 10 cost £40 million a year to the NHS, and is the biggest cost to the NHS for this age group across all areas of healthcare. Also, data from the Royal College of Surgeons shows that the average 5-year-olds consumes their own weight in sugar each year. so quite a lot of sugar. The good news is that we have evidence-based interventions, and we know tested and seen the interventions that could be done to prevent this. Public health interventions that can be both universal or targeted to certain groups to improve oral health and reduce inequalities. And the main interventions are really around reducing sugar, increasing exposure to fluoride toothpaste, and routine visits to the dentist. Now, when it comes to adult oral health, this was the data about children. So if we look at adult oral health, again, the same principles applies, and the children data can be used often as a proxy indicator because we don't have very recent and up-to-date data for adult oral health. We can use the children data as a proxy indicator. So some of the things that we can talk about are around oral cancer for adults, and the risk factors about smoking and alcohol are the same that we mentioned, and the impact on general health as well. So we know that, for example, for people with diabetes, if they also have gum disease, if you treat their gums to reduce the gum disease, you could reduce their diabetes outcomes equivalent to adding an extra drug in their treatment regime, but without the side effects of that extra drug. So it's really a non-invasive intervention, or doesn't really create any side effects, and it could improve not just the mouth, but also the rest of the body.
Super. I'm going to stop you there because it's really really interesting report now. We've got a few questions that may trigger as there's some other elements, if that's okay. So Councillor Barnes first, then Councillor Megan Swift.
Thank you, Chair. I think, this is nothing to do with Stefan. It's disappointing that NHS England seem to have stopped engaging with us on this, which has prevented me making an update on the work that we're trying to do. And I think one of the concerns we have, and maybe linking it in with maybe Stefan, is the apparent disconnect between the NHS UDAs that have been allocated to Calderdale and where those figures have come from, and how they've worked those figures out, and how they've determined where those figures come from. And that's a key issue that we're struggling to come up with, is how NHS England have decided Calderdale deserves X amount of NHS UDA treatments. And there seems to be no, it seems to be like, I was going to say pulling teeth. Sorry, folks, really apologise. Anybody on YouTube, I do apologise. See me afterwards. But it is that. And Stefan, I just wonder, Stefan, whether all this work that you're doing on all, is it feeding into NHS England so that they understand what's going on in Calderdale? Because at the moment, it just seems to be someone puts a finger in the air and goes, that much.
Thank you. And just before you come back in, is if anyone can help us in terms of that cooperation, then that would be most helpful, because we are struggling to get them to engage with something that we can equally help them and see where we can move forward. So, Stefan, thank you. So, if you'd like to continue, please.
Sure, thank you. If I may, it's really, I cannot speak on their behalf, but we exactly, this is a very, very good point. I know they are very busy, but we have now set up a joint oral health advisory group between Calderdale and Kirklees that we set up just before the pandemic started, and we had, I think, 2 or 3 meetings, and the group meets I think 3 times a year, and the idea would be for this forum to engage, because this oral health advisory group has representatives both from the council in Calderdale and Kirklees, but also from NHS England, local dentists, Public Health England, Health Watch, and other organizations. So it's really a forum to bring all these local stakeholders together and engage. And unfortunately, I think because of the pandemic, we stopped having those meetings, but we just had one a few weeks ago that Mike Lodge attended as well. And we are looking forward for the next meeting. And hopefully NHS England will be part of that meeting as well, and we can engage with that conversation. So really, the one of the main reasons that I'm here, and thank you for this invitation, is to bring to your attention the work that we've done in terms of the needs assessment and the strategy.
Yeah, very much appreciate that. So I'm going to bring in Councillor Swift in at this stage, if that's okay, please.
Sure, thank you.
Thank you. I'm one of those people who is absolutely terrified of dentists, you know, and I know dentists charge, but I think really they should pay me, because when I go, I'm really not happy. But seriously, I was trying to find an NHS dentist. Got things like, oh, we won't have any for 5 years. Now, I don't know how they know it's going to be 5 years, but lots and lots. I finished up having to go private, because just about everything's private where I could find them. And the dentist is really lovely. It's fine. But, you know, this year we can afford the money to pay it. There'll be a heck of a lot of people out there that can't. And so you don't have everything done that you need, and you're going back to an emergency again. So I always assumed there'd be some dentists that did NHS and some dentists that just take private patients. But from what I'm picking up, the dentists say they don't earn enough money with the NHS dentist, and I don't know if that's right or not, but it's really frustrating, you know, for somebody who doesn't like dentists, to have to keep waiting and ringing up on one thing and another, and then spending money that had been allocated for something else, but it's on my teeth now.
Indeed, thank you, Councillor Megan Swift. Can I suggest, Stefan, that you actually a meeting set up between this subgroup that's looking into this in more detail? I think that will be actually really helpful, and to move things forward. You know, so because actually what we want is to scrutinise an end report. You know, very much appreciate the information you've shared with us tonight. Colin, Councillor Hutchinson, please.
Can I just ask if that report is going to be forwarded to us, because I haven't picked it up. Or is it somewhere in my inbox?
If you can arrange to resend that would be most helpful, because I think we either missed it. We get a large numbers of emails, like I'm sure everyone else does, but so it's easy to miss. Stefan, would you like to come back in on that?
Of course, thank you. If I may, I'll send it to Mike Lodge and he will forward it to the members.
Super. And finally, Mike, would you like to come back in?
Just to say, I think with apologies to the board, we may have overlooked to forward that briefing note, but I'll get it out to you as soon as I can. And just to say, we haven't given up on trying to meet with NHS England to talk about their commissioning work. It's been really difficult to find a slot that they can make in the diary, because we want to talk to them in more detail about their commissioning approach, and also about a concept called flexible commissioning that they are implementing, but we have little detail yet about how that's actually working in Calderdale.
Indeed.
And just to come back, Howard, Stefan was on the list of future meetings in our
even better
bite-sized chunks approach.
Yeah, absolute.
I could go on all night. I could go on.
Well, absolutely. This is the whole thing. Let's move swiftly on. Councillor Parsons-Hulse, please.
Thank you, Chair. Can I ask a bit of a naive question? As a new member to this board, is there a reason why we don't have the dentist? So obviously, when we were younger, a while ago, we had dentists coming into the school, and those dentists used to pick up the, let's just say, the lower socioeconomic groups, you know, because everybody would trundle in, you'd be seen, and then, you know, people who didn't get taken to the dentist would obviously be seen. I'm just wondering, is that something that is not practiced in this area? Can you enlighten me, please?
Thank you. I think part of this will come in out of the report itself anyway, but I know, Sandra, you put your hand up, and welcome to the meeting, of course.
Thank you, Chair.
Thank you. Just in response to that particular question, the reason why dentists are no longer going into schools in the way you describe is essentially because it doesn't actually make any impact on the oral health of children. I mean, I can even speak from personal experience, having been around long enough that I worked in a community dental service where in the early part of my career, we did do school screening. And I'll give you an example. Say in a particular school, if I handed out 100 letters saying, I think your child needs a further examination, maybe a small proportion of those would go and pick that up from a dentist, but where we also offered to provide that care, we'd maybe get 25 responses. We would then send appointments out and trying to contact those parents, and bear in mind that we were probably, by comparison with maybe many high street dentists, very lenient in the community dental service, in that we'd try to get these kids in 2-3 times. We'd maybe then examine 9 or 10 of them, and in reality only 2 or 3 would ever complete treatment. So in terms of a lot of this, it starts from
a lot of effort for not a lot of outcome.
It's exactly, and it's not the best use of resources, but
that's really useful.
Our efforts are probably better spent working with mums very early on and trying to get them into practices early.
Yeah, thank you for that. Thank you, Chair.
Thank you, Debs. Can I bring you back in?
Yeah, it was just to make the point Sandra's made, really, the emphasis and the evidence and the focus really now is on those really early years. So as prior to teeth coming through, and as teeth come through, really try to get fluoride toothpaste on those teeth. And we work a lot. We work very closely with our children's centres in our early years settings as a partnership to really promote oral health in those really early years. And we know, don't we, Sandra, that tends to make more of a difference, but it also allows us to really target the support where we need it to be. So that's the sort of approach we take. And obviously, it's really important to be clear as well that one of the key evidence-based and effective interventions is fluoridation of water. And I can't sit here and not make that point. Where I used to work in the West Midlands, but prior to coming up to Calderdale, I couldn't believe how good the oral health was, having always worked in the north, and it turns out it was because the water was fluoridated, and it really does make a difference to children's oral health. And it's really important that we do take that preventative approach, as Stefan talked about. So we really don't want kids to be getting to dentists and needing treatment as young children. We want to be trying to keep the teeth healthy right from the outset.
Thanks, Debs. Perhaps it's maybe one of the outcomes that it goes to a recommendation eventually to Cabinet that actually a debate about florism is taking place. I know we had one quite a number of years back, and we decided not to go. There's mixed views, as you can imagine. So thank you, Stefan, for giving us an update. I'm sure you work with the team that's looking into this anyway, and we'll come back and we'll see you at a future meeting, I'm sure, so that we can ask you some additional questions based on some information as well.
Thank you very much. Thank you.
No problems at all. So we now go on to item number 8, which is the COVID-19 update. Debs, you've been a superstar throughout the whole pandemic. We always acknowledge you. We acknowledge the updated information, the hard work that you and your team put into all this. What in my view, is looking at your role in your predecessor, and actually it's really highlighted the need for public health moving forward and put you up on the top rein of the ladder, really, in some way. So and that's down to you. I think all your hard work. So without ado, a bit of an update. My recommendation is, as we move forward, is potentially to do it as a noting a point at the end, so people have something to say about it. Then, yeah, you've just muted yourself as well. So yeah.
Oh, sorry. Yeah.
No, it's okay. No
yeah. Thanks for your kind words, Chair. And just be absolutely clear, this is a massive team effort from not just my team, but across the whole the NHS and our social care partners and schools, and this is an enormous team effort. So, and I'm sorry, because my normal item has the word oral in it, and this previous item had the word oral in it. I got confused, so apologies for that. So yeah, what I was going to do, just really briefly, I'm conscious that we're at a pivotal time, aren't we, now, in terms of COVID. So I was just going to give a very brief sort of update, recognising that the roadmap comes to a conclusion on Monday. I think it's really important that we're all clear that although the restrictions end, COVID-19 will not end. And it's actually clear that we are now in a new wave of COVID-19 driven by the Delta variant, and as we know, that spreads much more easily. So it just the figures for the most recent 7 days, so that's the 4th to the 10th of July. 815 residents of Calderdale tested positive in that 7-day period. That gives us a case rate of 385 per 100,000. That's an increase of 18% compared to the same day the previous week. Calderdale's ranked 84th out of the 314 lower tier local authorities with that case rate. This number of cases now, sadly, is higher than the peak that we saw in January. It's not as high as the peak we saw in November, but it's as high as the January peak. And think back, I think, to what it was like in January. I think the good news is that the rollout of the vaccine programme means that this increase isn't leading to the same increase in serious illness and deaths that we've seen earlier in the pandemic. And just wanted to give a little bit of a sense of the scale of this. So back in January, 1 in 10 cases, COVID cases translated into a hospital admission, and 1 in 60 cases led to a death. Now, because of the success of the vaccine programme, 1 in 50 cases is leading to a hospital admission, and 1 in 1,000 cases is leading to a death. So we're working to prepare for what might come next. We're updating our local outbreak plan that we shared at the previous meeting, and also we're focusing particularly on living with COVID. We've never had, I think it's really important that committee is aware that we've never had case rates as high as we've now got in Calderdale without having restrictions. So we're now in uncharted and unprecedented situation. We've got the benefits and the fantastic progress with the vaccination programme, but equally the vaccination programme alone, it's not finished, it's not completed, and the vaccination programme alone will not prevent serious illness, I'm afraid, and death from COVID-19. So if we work through what might happen in terms of numbers, so if we go back to November when we had the highest, which was our peak, we had just under 1,000 cases a week. And that translated into between 80 and 90 people needing hospital care and 13 people a week dying. If we look at what might happen now without restrictions, even with the current number of people vaccinated, we could double the number of cases could be double what we saw in November. So we could get up to 2,000 cases a week. And what that might mean if we follow that through in terms of the figures now, we would expect to see 40 admissions to hospital a week and 2 people dying a week. And obviously, while that's significantly less than what we've seen previously in the pandemic, that will lead to, that will give a cost to local families and actually to the health and care system. And our health and care system is under pressure at the moment before we even see that impact. The other thing that I think it's important to say is that government modelling anticipates that we're going to have high numbers of cases until at least the end of August and probably more likely into September. What they have said is in the modelling that's been done is that the peak of the wave that we're currently in, it will be lower than previous peaks, and it will also be lower if the return to the behaviours we used to do before the pandemic, if that's gradual, if that change to the way we behaved before the pandemic is very quick, then it will lead to a bigger peak. If those changes happen over several months, we'll have a lower peak. So that's why it's really important. And as a council, we are encouraging people to continue to work from home where possible, to use masks in crowded indoor spaces, giving people space increasing ventilation, all of those things will those keeping some of those measures will help reduce transmission and reduce the size of the peak, and ultimately help protect our NHS services, actually protect our local economy as well, because if businesses have to close because staff are isolating or because they're unable to work, that will impact on local businesses, and also the business continuity of our own services as a council. The lower we keep case rates, the more we'll be able to carry on delivering our services. But ultimately, by doing that, by asking us all to be kind and considerate and think of others, it will also save lives. So I think in conclusion, Chair, I think it's important that what we're saying is we're asking people really to remember that not everyone feels the same about the ending of restrictions as we do. You know, some of us are really excited, think it can't come too quickly. Some of us are really anxious, and others of us have got mixed feelings. So I think it's really important that we're all think about the people that may feel differently to us, and think about being considerate and kind to them. So I'll end there, Councillor Blackburn.
Thank you, Debs, as always. Councillor Kingston, you have a question, and then Councillor Hutchinson.
It was just to ask Debs about plans for booster. Are there plans underway for a booster programme in this coming winter for vulnerable people in Calderdale?
Yes, there are, Councillor Kingston. The letter was published today, so there's been the information has come out today with the detail of that booster programme. I have to confess I haven't managed to read it yet. I was going to read it after this meeting, but what that focuses on is in the autumn a booster for those people that were in the top priority groups for the original vaccine. For some of those groups, it's a little bit different, but largely it's those people that are at greatest risk. And we are in Calderdale looking at how we can link the work we'll be doing in the autumn on the flu vaccine with the work, because some of the people will be the same people with the work on the COVID booster. So we'll be able to give you more of an update in one of the updates that I provide, and I'll probably do that in the update that you'll get over this weekend.
Excellent, thanks, Debs, for that. So, Councillor Hutchinson, please.
Thank you. Somewhere around about 1 in 20 people have immune systems that don't function well, either because of drugs that they're taking for cancer or rheumatological diseases, or because they've had organ transplants, or because they've got underlying diseases of their immune system as well. What are we doing to actually try and allow them to have as normal a life as possible, and to support them in whatever way they are going to actually have to be living for the foreseeable future?
Do you want me to answer, Councillor Blackburn?
Yeah, please. Yeah, no. Yes,
yeah,
please.
I am one of these people, Councillor Hutchinson. I am one of these 1 in 20 people due to the stem cell transplant that I had for leukemia. So and I think this is one of the reasons why we are appealing to people to be kind and considerate and think of others. It's really important to understand that there are some people who vaccines don't work as well for, so they'll have the vaccine, but the vaccine might not be as effective, and that's why never ever a vaccine programme on its own is the solution. So it is really important that in high-risk places where people come together, that we do carry on wearing masks, that we do give people space, and that we do, if we've got symptoms, go and get a test and isolate. This is not over. It's still important that people get tests. And I think, there are some measures that are being taken. So, for example, you'll be aware that in West Yorkshire, the Combined Authority, the Mayor, has announced that we will be asking people to wear face coverings, to continue wearing face coverings on public transport. We are doing a review of our outbreak plan to look at the support to people that are vulnerable. There's a whole range of support. As you know, our communities have stepped up through lots of mutual aid groups and things to make sure that we support people. But I think you know, I think, and I can speak from personal experience, it is a really worrying time. You know, it's really quite anxiety provoking for people who we know the vaccine doesn't work as well for, or maybe can't take the vaccine. And I do think it's really important, and that's one of the reasons, as I said, Councillor Hutchinson, that we're encouraging consideration. I think it's really important that people who are vulnerable can get on with their lives and enjoy their lives. They've been very isolated often, and it is really important that they can go about and participate in the everyday life of society. I do think this is going to be a challenge, but we are, through the work that we are Clinically Extremely Vulnerable programme, looking at how we can make sure that those people get support. But I think this is it's a really good question and a real challenge for us.
Thanks, Deb. Councillor Megan Swift, then I'll bring in Councillor Fenton Glynn. You?
Yeah. Yeah. I mean, this is an old question, Deb, so I'm sorry, but the more things come out, I mean, kids in school at the moment seem to be going down like flies, and you know, nearly everybody you speak to says, "Oh, I had so-and-so's at home this week," you know. It worries me that the cut-off rate for vaccine doesn't include, you know, primary age kids, and I wondered if it had been tested or it was just not felt suitable to give children.
Thanks, Councillor Swift. The reason I'm looking away is because I'm looking at my notebook to let you know how many schools have got outbreaks at the moment. It's unprecedented, Councillor Swift. We've got outbreaks in 23 schools. So at the moment, we've never had this level of outbreaks before in our schools. And as you know, we will be sending you an update tomorrow with a summary of those. It's to do with it's basically you know, whether the vaccine's been tested on children, whether it's regulated in terms of the use of children, and whether it can be used. It's been identified as being able to be used on children. There is, as you know, research going on to look at the different vaccines and to look at whether they are safe and effective for children. So some of the vaccines, as you know, there are side effects, a very, very tiny number of side effects, but the need to be balanced between having the vaccine and the benefit. And as you know, it does appear, from everything we know so far, that children do have much less effects from COVID-19 than adults, so they're much less likely to get ill, to get symptoms, or to get longer term symptoms. There's also some evidence that suggests that, you know, they are significantly less likely to get long COVID and some of the other health problems associated with COVID. So for that reason, at the moment, the vaccine programme doesn't cover children. As I say, that might change over time as the vaccines are tested, and obviously we'll see what happens. As you know, things change and develop.
Yeah. Thank you, Councillor Clark.
Thank you, Chair. That was quick. I'm just wondering, Debs, are we going to continue the COVID coordination groups? I'm just wondering about the reception of those volunteers and the people who are working for yourself on the street, and what sort of reception they'll get. I'm a bit worried about how that will be received by the general public, but we can't really stop them. We can't stop the coordination groups, because I do think they're vital. Otherwise, people will forget that actually there is still a danger. Yeah.
Debs, do you want to come back in quickly on that one? You just on mute, I'm afraid. Sorry.
Sorry, really
okay.
quickly. really quickly. I think there's a number of groups out there. I think the mutual aid groups. I think while people are still worried and still anxious, I think those mutual aid groups have got a really important role to play. I think we tend to do the street-based engagement that you're aware of when we have an issue. So if we have a really high case rate, we have lots of people becoming ill or going into hospital. So I think we will step that back unless there's evidence that we in a particular local area that we need to do that. Councillor Clark, and then the final element of this is the local contact tracing, which we do everything. We do it all now, and again that will need to continue. Because we still need to speak to people that test positive, find out who they've been in contact with, and ask them to isolate. So I think that will need to continue for the time being.
Thank you. Councillor Fenton-Glynn, I wasn't trying to ignore you. You put your hand down and put it back up. So you're trying to see if I'm away still. So I am. So there we go. The floor is yours.
Yeah, no, I put my hand down because I thought, I thought I was in the queue. But it was just really just to kind of reiterate some of the conversation that we just had earlier about the fact that we are opening up, but there remains a risk, and just to urge people to think about that risk as we do go into opening up. And it's one of those things where I think, we talk about the kindness that defines Calderdale, and actually that understanding is really important. And I'm sure everyone else in their local communities will know of shopkeepers and so forth who are very nervous at this time. And I think we need to just make sure that we're not drawing a false dichotomy between opening up and safety measures. So, for example, there's a local business to me who aren't operating in the same way at weekends because they just don't want people in without masks at weekends, because they recognise, because one of the people who runs the business is in a clinically extremely vulnerable group. So it's just quite a simple plea to anyone who's kind of listening from Calderdale that, these people are still at risk groups. The risk of getting COVID is somewhat greater with the Delta variant, although the risks associated with it aren't perhaps as great. But then also the risks of long COVID remain, and frankly, we just don't know the long-term impact. So kind of from my perspective, I think we do need to make sure that we aren't, it's not a choice between opening up and being responsible and considerate. It's the only way we're going to do this successfully as Calderdale is by doing them both together.
Thank you. And Councillor Barnes, a very last and hopefully very quickly.
I'm always quick, Howard, you know that. I think interesting moment in time is not really the right phrase to use, but it is a sort of are we achieving the watershed moment? And I think and we've talked about this, Howard, and I think we want to just flag up that obviously, Debs has spent 13, 14 months here on COVID, and the things that she was brought in for, she hasn't been able to do. And I think we have to recognise that, and we have to recognise that we are now in the situation where over the next period of time, those are going to come up, and we're going to need to be. I know we're arranging discussions with that, and the same with Ian, and the same with Councillor Fenton-Glynn with regard to his position of cabinet. I think we need to make Scrutiny aware of that, and those are the things that are going to come. It's COVID isn't going to go away. It isn't going to go away next week. It isn't going to go away the week after. But at some point, those other items which we've not been able to deal with are going to come up, and they are going to be some difficult choices and some difficult issues difficult things to say and talk about at those points. So I just wanted to sort of make other Scrutiny members aware of the conversation we've been having on these very subjects.
Yeah, excellent. Thank you for that, Councillor Barnes. It is important. It's the effective communication, as I spoke about earlier. So yeah, thanks, Debs, for the update as always on this one. So that concludes item number 8. So we're going to the work programme, which has been circulated. Equally, we've had a meeting with Councillor Barnes and Mike, and we've been going through fitting things into the work programme that will fit in. And we're forever, it's never changing situation. our doors are always open to include additional things and additional things crop up, like communication tonight, for instance. So, Mike, do you have anything to add to that?
Just to say, Chair, that following the discussions with yourself and Councillor Barnes, we've updated the work plan. It's taken on account of a number of suggestions that Councillor Hutchinson has made in an email. We'll update it following this evening's decisions and circulate it. If not tomorrow, then we'll circulate it on Monday. We've got, actually, I think it's turning out to be a really good work programme. And in August and September, we're inviting CYP, Children and Young People Scrutiny Board members, to join you to discuss the suicide prevention discussions in August and the health and care bill in September.
Thank you very much indeed. So equally, email me at any time if you wish to add anything to the agenda. For those new on the panel this evening, thank you for attending. Thank you for your contribution. I hope you enjoy a little bit of what's left of the warm weather outside. And I would officially close the meeting and say thank you for officers and everyone for partaking in this meeting. So have a good evening, everybody.